So as a GI fellow, I get called by the ER and medicine services quite a bit. These are 3 of the most common misconceptions about GI and hepatology that I hear from other doctors when they call me. Acute liver failure's definition. Many times patients with worsening liver disease come to the ER because they look yellow and they feel terrible. A bilirubin of 30 is certainly concerning, but it has nothing to do with acute liver failure. It could be due to worsening cirrhosis or obstruction. Acute liver failure is defined as acute liver injury, elevated INR, and confusion, and it's an emergency. 2. Diagnosing SBP. SBP stands for spontaneous bacterial peritonitis, and it's an infection in the abdominal fluid called ascites, which is a common complication in patients with liver cirrhosis, and it often causes pain. Sometimes doctors don't check patients for this infection if they don't have pain, but up to 1/3 of patients with SBP have either no pain or vague symptoms like confusion. Every patient with cirrhosis and ascites being admitted to the hospital should get a paracentesis to rule out SBP. And lastly, a positive FOBT or FIT test has no impact on the urgency of a scope or the diagnosis of a GI bleed. Those tests are intended to screen for colon cancer, and they can be positive even if a patient isn't having an active GI bleed. As a GI fellow, what I want to know is if they're vomiting blood or seeing blood in their stool. Thanks.